Hi everyone, welcome to 1PM. Just a reminder that you're listening to the summary version of this episode.
Let's go to the OSCE station. So you are an RMO working an overnight shift at King Edward. The on-call senior registrar is down in theatre doing an emergency C-section. You're paged by the senior midwife to come down and review a 36-year-old woman who has delivered a baby boy 25 minutes ago. Delivery was normal with normal first and second stages. She's bleeding with an approximate blood loss of 800 mils, but the source has not been identified and is not stopping. What do you do?
All right, so while I'm walking, I'm thinking about the A to E assessment that I will be doing on this patient. But I'll also check on any records, medical.
Yeah, so quick history,
Yeah.
right? So what are we looking for in a history for this patient?
The risk factors.
Yeah, assess the risk factors. Number 2, is the patient stable? It comes in AAT assessment. Number 3, has the placenta been delivered and how much uterotonics have been given and what have been given? Quantify blood loss, gravida and parada.
Yeah, okay.
Any infections? And if you're going to theatre, you can do an ample history. Do you know what an ample history is?
A for allergies.
Yeah.
M for medication. P is for past medical history. L is last time you
Last eaten. Right.
ate or drank.
Last eat or drink, right? If you're thinking of the AD assessment, what does that entail?
Airway. So airway. So I'm saying, is the patient talking? Does she have an airway? Is it patent? B, so I'd be doing a rates assessment. So rate stands for R is rate, respiration rate. A is auscultation of the chest. T is tracheal position, so checking if it's midline. E is effort of breathing. And then S is your SpO2, so your blood oxygen saturations.
So, trick question. Not a trick question, but A and B should be assessed very quickly unless the patient is peri-arrest. So A and B actually don't matter
Yeah,
unless they're about to die. C is where the chunk of information is. So as we know, what do we do in C?
More vital signs relating to circulation. So heart rate, blood pressure, just peripherally seeing if they're compromised. So are they cold or clammy, capillary refill time. Kind of related to that would be the urine output.
It's just assessing whether they're stable or unstable. Right?
Yep.
Are they stable or unstable? And number 2, we should ask in circulation for obstetrics is, has the placenta been delivered?
That's the unique thing about
That's
it.
the unique thing about C. And then ask what drugs have been given to augment this, if not already said to you. And then obviously, we all love IV access, 14 gauge if possible, because 14 gauge is the pregnancy one. Then what we do after that, we've got IV access, magically, because we were really good interns. What do we do next?
Take off some bloods.
What bloods do you want to send?
But I would do the full gamut of bloods. I do FBC, UEC, LFT, specifically pertinent to her bleeding case, a group and whole, a cross match, a rotem, if they haven't been done before. And if I think she's septic, blood cultures.
Yeah, so full blood count, coags, group and hold, cross match. And you can also activate the MTP, but obviously this is not an RMO decision. It's a senior decision. But I guess you
the what?
massive transfusion protocol.
Yes.
In an OSCE, guys, if you know there's bleeding,
Yeah.
activate the massive transfusion protocol, guys.
I guess you about 4 bags of O negative. And also, as we all love, start fluids, crystalloid fluids.
Mhm.
And you can give 500 ml boluses for 3 times the estimated loss. Now we're on to D. What's D?
Disability.
Yeah, in obstetrics, it's drugs. So you check, again,
Check what, like how
all the
much
drugs, like
oxytocin
the
they've been given or-
oxytocin, tranexamic acid. Now we have E, everything else, or exposure. This is where the 4 T's come in again. What are the 4 T's again?
Tone, trauma, tissue, thrombin deficiency.
Quickly running through the management for each cause. So tone, non-medical, medical, surgical. Non-medical, we can do IDC, catheter, uterine massage, and bimanual compression. Pharmacologically or medically, we can do syntocin infusions or ergometrin. We can also give TXA, which is tranexamic acid, and other uterotonics such as PGF2 alpha. And surgically, we can do balloon tamponades, Belian sutures, uterine artery ligations, and hysterectomy as our last resort.
So when you're managing trauma, non-pharmacologically, you want to compress the area or put packs there to help clot the blood. And you want to examine and see where the bleeding is occurring.
Yeah.
And then medically, you want to give TXA to help clot the blood. And then surgically, you want to suture the cut or tear. Because that's the definitive management.
Yep. So for tissue, we want to examine the placenta and membranes and ensure they're all intact. And then pharmacologically, we could give uterotonics to help pass any of the membranes or placenta. And then if we're still concerned, we could take the patient to theatre to remove any of the products.
Last one, thrombin.
You would call the lab to assess what type of clotting deficiency they have and do a rotum, and then you replace the clotting deficiency with whatever they need.
They tell you.
We can also give TXA.
Oh yeah, you have TXA. Yeah.
TXA.
But that's a given.
Just as like a stopgap measure more than anything else. If the patient is rural, stabilize and transfer them to the nearest tertiary center. Don't forget document. And that's it. We're done.